Antithrombin 3.
Antithrombin 3. Yes. Can you classify on the basis of groups of reading? Only heparin is there in anticoagulants. Only heparin? Anybody? How will you classify anticoagulant drugs? First, you can classify on the basis of either it can be used in vitro or in vivo. So in vitro, we have different drugs: heparin, sodium citrate, sodium oxalate, sodium edited, and those drugs which can be used in vivo. We can classify either they can be used by the parenteral route or they can be used by oral route. Under parenteral also we have the indirect thrombin inhibitor, direct thrombin inhibitor. Okay, and under oral we have different derivatives: coumarin derivatives, indodione derivatives, direct factor 10A derivatives, inhibitors, and direct thrombin inhibitors. At least you should know one drugs in each group. So in the last class, we finished heparin and low molecular weight heparin. So what are the uses of heparin, you know? Do you remember something? What are the clinical indications? Why nobody is responding? You haven't read anything? What are the clinical indications? What are the therapeutic use of heparin?
DVT.
What is DVT? Tell me in full form.
Deep
Vein thrombosis.
And any other? There are so many uses of heparin, anticoagulants.
Prophylaxis of angina.
Okay, prophylaxis for angina, myocardial infarction. Yes. Other?
Coronary
Cardiac
angiopathy.
surgery. Okay, coronary bypass surgery. Okay, during and after coronary bypass surgery, after coronary angioplasty, and while the patient is undergoing dialysis, you can give anticoagulants. Okay, to prevent the clotting in the cannula. Okay, catheter. So these are the some of the useful clinical indication of heparin and low molecular weight heparin also. Okay, same, almost similar clinical indication. So do you know differences between these two? Low molecular weight heparin and unfractionated heparin or just heparin. What are the difference between between these two drugs?
Low molecular weight heparin has less side effects.
Okay, less side effect. Other very important difference in this.
Low molecular weight heparin does not inhibit thrombin.
Okay, factor 2. Why?
Because it does not have large size and large size is required.
Okay, that is complete occupancy of the both factor as well as the antithrombin is required in case of factor 2. But such occupancy is not required, not essential. If it is occupied, then it's okay. Or if in some condition, if it is not occupied, then the factor 10 is also inhibited. Okay, that's why not factor 10. Okay, the factor 10 is inhibited by both heparin as well as low molecular weight heparin. But in case of factor 2, it is required the full occupancy of covering of all this factor, activated factor as well as antithrombin by the heparin molecule. So only heparin inhibit the factor 2. But the factor 10 is inhibited by both low molecular weight heparin as well as unfractionated heparin. Okay, that is the very important thing. So today we will be discussing the remaining anticoagulants. Synthetic heparin derivatives. In synthetic heparin derivatives, we have the fondaparinux and idaparinux sodium. Okay, these are the synthetic heparin derivatives. They are the pentasaccharides, so it has also a small chain. Okay, it is also low molecular weight. It binds to the antithrombin 3 with the high affinity, which selectively inactivate factor 10A. Okay, because it has a short chain, so it inhibits factor 10 only. It has a high affinity with the factor 10, activated factor 10, and thereby inhibiting its action and interrupt the blood coagulation cascade. And when it inhibits factor 10, ultimately it inhibits factor 2 also, no? That activated factor 2 again, that inhibit the prothrombin and this fibrin, and it again converted the prothrombin into thrombin and thrombin into soluble fibrinogen into insoluble fibrinogen. And the final result is the inhibition of this thrombin also. Okay, but its direct action is inhibiting this factor 10A, not 2A. It does not require routine lab monitoring like heparin. Okay, you do not go under that monitoring of the APTT level while giving this drug. So that is one of the advantage of this synthetic preparation. No lab monitoring is required. Advantage, bioavailability is 100% by subcutaneous route also. Okay, so you can give easily by the subcutaneous route. Long half-life, that is 17 to 20 hours. So you can give once daily dose. No frequency of dosing. Lesser antiplatelet action, so less chance of thrombocytopenia. Okay, thrombocytopenia. What is thrombocytopenia?
Decrease in platelet count.
Decrease in the platelet count. This thrombocytopenia is the main side effect, very common side effect of this heparin. Okay, that is heparin induced thrombocytopenia. So that type of the side effect is less in case of this synthetic preparation. Okay, fondaparinux. This can be used for the prophylaxis of thromboembolic condition. Okay, the patient who are undergoing the hip and knee surgery. The patient having thromboembolic condition and undergoing hip and knee surgery, in that case we can give as a prophylactic drug. Like in pulmonary embolism also we can use, and deep vein thrombosis. These are the uses of synthetic preparations. Now let's come to direct thrombin inhibitors. So till now we are discussing the indirect inhibitors. Okay, indirectly inhibiting by activating the or enhancing the action of the antithrombin 3. But this drugs, direct thrombin inhibitor, that means directly inhibits the activity of the thrombin, that is factor 2. So it binds directly to the thrombin and inactivate this thrombin activated factor 2 without the need to combine with an activate AT3. In this condition, that is antithrombin 3 is not required. So these drugs will go and directly bind to the activated thrombin and inhibit its action, thereby inhibiting the coagulation cascade. So in this we have these drugs, lepirudin. What is this creature? Do you know? In the figure?
Leech.
Leech. Okay, have you ever experienced by the stinging with the leech?
Yes, ma'am.
So how you experience that time? There is a bleeding or there is no bleeding, there is a clotting immediately after bite by this leech. What type of feeling you had at that time?
No feeling, ma'am.
Nothing. Any bleeding was there or not?
Bleeding was little, not
Only
much.
little for the long term or for the brief time, only short period?
Don't know, ma'am. Not given that attention.
Oh, okay. So this creature is a leech. Okay. In the leech, in the salivary gland of the leech, one of the peptide is present. That is hirudin. Okay. That hirudin is a peptide that is present in the salivary gland of the leech. Okay. That act as an anticoagulant substance or anticoagulant components. Okay. This lepiridin is the recombinant preparation of the same peptide. Okay. So it has an anticoagulant property, that hirudin. So whenever we are stung by the leech, there is a continuous bleeding. Okay, we cannot stop the bleeding because this has a anticoagulant component inside it in the salivary gland. So due to this anticoagulant properties, there is a continuous bleeding. Okay. So this is a lepiridin is the recombinant preparation of that same hirudin component. It is a polypeptide anticoagulant which is secreted by the salivary gland of leech. It binds to the active site of the thrombin factor 2 and inhibit it directly. Okay. It does not require any activation of this antithrombin 3, unlike heparin and low molecular weight heparin. It is indicated only in patients who are risks of heparin-induced thrombocytopenia. Okay, those patients who experience or who has a history of heparin-induced thrombocytopenia, in that condition, we can give this drug as an alternative. Okay, this lepiridin. We can give by IV route, and there is and monitoring of the APTT should be done in this condition also. Okay, activated partial thromboplastin times should be monitored while you are giving these drugs by intravenous route. Next drug we have the bivalirudin. It is similar to lepiridin in the mechanism of action also. It can be used in the coronary angioplasty as an alternative to heparin. So those patients who cannot tolerate heparin or due to any contraindication to the heparin, you can give this drug bivalirudin. You can give by the intravenous route. So all these drugs we are discussing, they are given by the parenteral route only. Okay. So they are the parenteral anticoagulant. We are discussing till now only parenteral anticoagulants. Next we have the argatroban. It is a synthetic direct thrombin inhibitor. Okay, this bivalirudin and the lepiridin, they are the recombinant preparation, where this argatroban is, it is a synthetic preparation of thrombin inhibitor. Okay, direct thrombin inhibitor used in patient with heparin-induced thrombocytopenia, and APTT is monitoring is required. It also can be given by the intravenous route. So this is heparin antagonist, that is a protamine sulfate. These things I have already discussed while I taught you this heparin. Okay, whenever there is excess amount of the heparin and there is a excessive bleeding, continuous bleeding due to the heparin therapy, immediately you have to inject its antagonist, that is a protamine sulfate. Okay, this heparin is a negatively charged molecule, whereas this protamine sulfate is a positively charged molecule. So this negative and positive charge will combine and form a stable compound. Okay, thereby inhibiting the bleeding, the action of the heparin. It is a strongly basic low molecular weight protein obtained from the sperm of certain fish. Okay, this obtained from the sperm of the fish. Protamine sulfate can be given intravenously. It neutralizes the heparin weight by weight. Okay, when you give 1 milligram of the protamine sulfate, it will inhibit the 100 unit of heparin. It will neutralize the 100 unit of heparin. 1 unit, 1 mg is equal to, that is equal, not is equal to that neutralize 100 unit of heparin. You should know this. This is important. Used when heparin action needs to be terminated rapidly in some condition, like after cardiac or vascular surgery, we have to give the very high dose of the heparin. So immediately after the surgery is completed, we have to terminate the action of the heparin to prevent the bleeding. Okay, to prevent the complication of the heparin, like excessive bleeding. Okay, in that condition, you have to inject protamine sulfate intravenously. The adverse effect of this protamine sulfate is hypersensitivity reaction, because it is cause the hypersensitivity reaction have occurred due to histamine release. Okay, it also release the histamine. Because of that, it causes hypotension, bradycardia, flushing, allergic reaction, and other like pulmonary hypertension also may be seen. And if you give rapid IV injection, it causes flushing and breathing difficulty. So this should be given by slow IV infusion. Okay, this protamine sulfate. And these all other are the these are the symptoms of hypersensitivity reaction due to the release of the histamine. Now we come to the oral anticoagulants. Okay, till now we were discussing the parenteral anticoagulants. In parenteral anticoagulants, we have the indirect thrombin inhibitors and direct thrombin inhibitors. Okay, in indirect, we discussed heparin, low molecular weight heparin, and synthetic heparin. Okay, and direct thrombin inhibitor. Now we will discuss oral anticoagulants. In oral anticoagulants, we have the different derivatives. Coumarin derivatives. In coumarin derivatives, we have warfarin, dicumarole, and acinocumarole. Next, we have the indadione derivatives, pheninidione, direct factor 10A inhibitors, rivaroxaban, and direct thrombin inhibitor. We have the dabigatran etelaxate. You should remember these drugs also. Okay, there are few drugs, only 1 or 2 drugs in each group, so you should remember this drug's name. So we talk about warfarin in detail. Okay, this is very important drugs that can be used in every thromboembolic condition. So it acts as an anticoagulant only in vivo, not in vitro. So we cannot use warfarin as an anticoagulant drugs in lab. Okay, we cannot use warfarin in the we cannot put warfarin in the bottle, okay, to prevent from its coagulation. Okay, that is, it cannot be used outside the body. Why? You should know this reason, because this warfarin, this act by indirectly interfering with the action of the vitamin K. Okay, this vitamin K is required for the activation of the clotting factor, different clotting factor, that is factor 2, 7, 9, and 10. Okay, these factors, they are activated only by the vitamin K in the liver. Okay, so that we cannot use this drug outside the body. So this warfarin can be used only in vivo, not in vitro. Okay, this acts as a competitive antagonist of the vitamin K, so thereby inhibiting the action of the vitamin K in a dose dependent manner. So you can see here in this figure, this I have already explained while I taught you that vitamin K, how the vitamin K is required for the activation of the different clotting factor, that is factor 2, 7, 9, and 10. Okay, these are the vitamin K dependent clotting factor. So this vitamin K is required for the gamma carboxylation of this residue, okay, glutamic residue of this clotting factor. So this vitamin K initially in the reduced form. So for gamma carboxylation of this inactive precursor, it has to be converted into oxidized form. So when this reduced form is converted into oxidized form, then it causes the gamma carboxylation of this inactive precursor or inactive precursor of clotting factor 2, 7, 9, and 10, so that it become activated. Okay, these factors get activated, and thereby they have the capacity to bind to the other substance like calcium and phospholipid, okay, to initiate the cascade of the reaction. So this vitamin K is now in the oxidized form, and again it has to be converted into the reduced form for the gamma carboxylation of this clotting factor. So this things is done by this vitamin K reductase, that is oxidized form is converted into reduced form with the help of certain enzymes that is known as vitamin K reductase, okay, epoxide reductase. This oxidized form is the vitamin K epoxide, whereas this vitamin K reduced form is the hydroxyquinone form. Clear? So this step is inhibited by the warfarin here. Okay, this warfarin inhibits this vitamin K reductase, thereby inhibiting the conversion of this oxidized vitamin K into the reduced form, thereby inhibiting the gamma carboxylation of this clotting factor, thereby inhibiting the activation of the clotting factor. Clear? How this warfarin act, or how this warfarin act as an anticoagulant? Now the pharmacokinetics. Okay, oral bioavailability is 100% warfarin. So you can give by the oral route. So they are classified on the oral anticoagulants. Because if you give by the oral route, also it has a 100% bioavailability. It's like of the IV route. 99% is bound to the plasma protein. Plasma half-life is 36 hours. It is metabolized in the liver and undergo enterohepatic circulation. Okay, if some drugs which undergo enterohepatic circulation, the plasma half-life is increased. Okay, because the same drugs is circulating many times. Okay, in the liver, that increase the half-life of the drug. And the metabolized urine, and this warfarin that can cross placenta. Okay, so you cannot give these drops in the pregnant lady, that may produce teratogenic effect. Can you give heparin in pregnant lady?
Yes.
Yes, ma'am.
Why? Doesn't it have any teratogenic effect?
It is highly acidic and it is high molecular weight. It cannot cross the placenta.
Okay, it has a very high molecular weight, so, and it is a highly ionized molecule. Okay, so it cannot cross the placenta. Also, it cannot cross the blood-brain barrier. So it has a very minimum CNS effect, as well as it doesn't have any teratogenic effect to the fetus. So you can easily give heparin in pregnant lady, but this warfarin, that it can cross placenta very easily. So it has a various teratogenic effect, like there is a birth defect. Okay, that is bone retardation of the fetus, cleft lip, cleft palate, and so many teratogenic effect that is seen in the fetus if you give warfarin. Okay, so it is contraindicated in pregnant lady. The anticoagulant effect take 1 to 3 days to develop. So it takes more time to show its anticoagulant effect. Okay, this is also very important. Why? There is a delay between administration and the anticoagulant effect of the warfarin. So if you give warfarin today, after 3 days only you will see the result. Okay, you will see the anticoagulant effect of the warfarin, because this warfarin act by inhibiting the that vitamin K dependent clotting factor. Okay, so this clotting factor, these have the different plasma half-life. Okay, so to act is effectively, it has to decrease the level of factor 2, factor 7, factor 9 and 10. Okay, because all these factors, they have the different plasma half-life, but there is longest half-life of this prothrombin. Okay, prothrombin, it has a 2 to 3 days half-life. So to show its effect, it has to neutralize this prothrombin also. Okay, but when you give warfarin, already there is some prothrombin in the plasma. Okay, that should be neutralized to show the anticoagulant effect. Okay, so for that reason, this warfarin will take about 1 to 3 days to show its anticoagulant effect. Okay, to neutralize the prothrombin that is already present in the plasma before giving warfarin. Okay, this is the reason why this warfarin takes long time to show its anticoagulant effect. So this is the reason why this warfarin cannot be given in the emergency condition. Okay, in the emergency condition, always you have to start with the heparin. Okay, because heparin, it has an immediate action. When you give by the intravenous route, it has a very rapid action. So after 3 to 5 days of giving heparin only, then you can start with the warfarin. Okay, because it has onset of action is delayed with the warfarin. Clear? This is a very important Viva question, okay? Why warfarin shows its effect after 1 to 3 days, or why there is a delay between administration of the anticoagulants and its effect, okay? And dose is regulated by monitoring prothrombin time. So while you are giving warfarin, you have to always monitor the level of prothrombin time, okay? Prothrombin time, and accordingly you have to give the dose of the warfarin. So do you know what is prothrombin time?
It is the test done to assess the extrinsic and common factor.
Okay, to either there is any defect in the extrinsic pathway or not. Okay, this prothrombin time is the time taken by the plasma to clot. Okay, you can see the time to clot of the plasma. Generally, normally it is that is 11 to 13 second in normal patient. Okay, without any defect. So you have to monitor the level of the prothrombin time while you are giving warfarin, okay, to prevent any bleeding complication. So if the dose of the warfarin is increased, okay, without monitoring the level of this, without monitoring PT, then the patient may have the complication like bleeding. Okay, to prevent the complication like bleeding, you have to always maintain the dose of the warfarin by this test, okay, prothrombin time. And APTT is used for, to know the why APTT is used. Yeah, intrinsic and
pathway
intrinsic
and
as well as common pathway. Okay, either there is any abnormalities or this pathway is interfere or not. So to check that, you have to do the APTT level. So this APTT is done in case of the heparin. Okay, but this prothrombin time is done in case of warfarin. Okay, to know any defect in the extrinsic pathway or not. So these things is very important, okay? Now the drug interaction, this warfarin has a various drug interaction. It can interact with the various other drugs. So you should be very cautious while prescribing warfarin. So you should ask the history of the patient, okay? Either the patient is taking any other medication or not, and which type of medication he is taking. So these things is very important, okay? While you are giving warfarin to the patient. Some drugs increase the activity of the warfarin, while some drugs they decrease the activity of warfarin. Okay, when there is a decrease in the activity and there is a soft therapeutic effect, okay, the drugs is not working efficiently. When there is an increase in the activity of the warfarin, and obviously there is a complication like bleeding. Okay, so you should be very cautious while prescribing this drug. The warfarin activity is potentiated with concomitant use of these following drugs. Enzyme inhibitors. Okay, there are various drugs which act as enzyme inhibitors. Metronidazole, chloramphenicol, disulfiram, erythromycin, cimetidine, allopurinol, and immunodarone. Okay, these are the enzyme inhibitors. So when you use these drugs along with this warfarin, and there is an enzyme inhibitors, that means the enzymes which metabolized warfarin, that is inhibited. So when the enzyme is inhibited, obviously there is an increase in concentration of the warfarin. No? Any confusion in this? While you are using enzyme inhibitor along with the drugs, then there is an increased plasma concentration of the drug. Okay, because the enzymes which is metabolizing the drugs is inhibited. So thereby increasing the concentration of warfarin and increasing the side effect. Okay, so never give this type of the drug, metronidazole, chloramphenicol, along with the warfarin. Okay, if you give along with this, there is complication like severe bleeding. Drugs which displace warfarin from the protein binding site, like cotrimoxazole, indomethacin, phenytoin, and probenecid. Okay, these drugs, they are compete with the same binding site. So when these drugs go and bind to the warfarin binding site, and the warfarin is released from the protein binding site, and the more concentration will be in the plasma. Okay, that will increase the effect of warfarin, and that result into the unnecessary side effect. Inhibitor of the platelet aggregation, like aspirin. Okay, this aspirin is an antiplatelet drug, so you should not combine warfarin with the aspirin because it has an additive effect. Okay, this aspirin also inhibits the platelet aggregation, thereby increasing the chance of bleeding. Drugs which inhibit gut flora, because gut flora, they are responsible, or they synthesize the vitamin K. Okay, and this vitamin K, they are required for the activation of the clotting factor. So when these drugs which inhibits the gut flora, that means the clotting factor is decreased. Okay, so broad spectrum, along with the broad spectrum antibiotics also, you should not use this drug because there will chance of bleeding. The action of the drugs will potentiate, okay, because of decreasing in the clotting factor. Drugs causing hypoprothrombinemia, so those drugs which decrease the level of the prothrombin also, that will ultimately increase the warfarin activity, like cephalosporin, third generation cephalosporin, cefaperazone. Other factors like hyperthyroidism. Okay, this patient having hyperthyroidism, hepatic disease also, there is an increased concentration or increased activity of the warfarin, because in hyperthyroidism there is an increased catabolism of this clotting factor. Okay, because of this the action is potentiated. In hepatic disease also, in hepatic disease the clotting factor synthesis is decreased. Okay, thereby increasing the effect of warfarin. So these are the some condition where there is an increased activity of the warfarin, thereby leading to the unwanted complication. Now some drugs which also decrease the activity of the warfarin. Okay, in that condition either you have to increase the dose of the warfarin, or you can change other drugs, okay, instead of warfarin. Otherwise, if you give this warfarin along with these drugs, then there is a soft therapeutic effect. Okay, the drugs will not work efficiently. Some drugs like enzyme inducer drugs, barbiturates, rifampicin, glycofulvin, and carbamazepine. So that is enzyme inducer, means the drugs will catabolize very fast or metabolize very fast. Okay, this barbiturates, rifampicin, glycofulvin, that cause induction of the enzymes. Okay, so when the enzyme is induced, there is an increased metabolism of warfarin, thereby decreasing the therapeutic plasma level of warfarin. And some drugs which inhibits its absorption, like sucralfate. Okay, it is the ulcer protective drugs that can be used in the peptic ulcer patient. So these drugs, this sucralfate, along this, when you give along with the warfarin, this warfarin and sucralfate will make a complex. Okay, when there is a formation of complex and there is no further absorption of the drug, thereby inhibiting the level of plasma concentration, that is decreasing the plasma concentration level of warfarin. Next is the increase the synthesis of clotting factor. Some drugs also increase the level of clotting factor. Okay, increase the synthesis of clotting factor, like estrogen containing oral contraceptive. Okay, this estrogen containing oral contraceptives, when used for the long term, that increase the clotting factor. So when the clotting factor is increased, obviously we need high amount of the warfarin. Okay, if the same amount or same dose of the warfarin is given along with this oral contraceptive, and there may be chance of therapeutic failure. Okay, either you have to increase the dose of the warfarin, or you have to stop this oral contraceptive and you have to give for alternative drugs. Other factors, hypothyroidism. Okay, in the hypothyroidism there is a decreased catabolism of clotting factor, because all the basal metabolic activity is decreased in hypothyroid patient, whereas increase in hyperthyroid patient. So the clotting factor catabolism is decreased, thereby increasing the clotting factor, so more warfarin is required in this condition. Okay. So these are the very important drug interaction of the warfarin. So always you have to ask the patient whether the patient is taking any medication or not. Either the lady is taking oral contraceptives. Okay, in that condition, you have to switch to other drug. Adverse effect of this drugs is, the most common adverse effect is bleeding. Okay, so to prevent this condition, always you have to monitor the plasma, that is the thromboplastin time. Okay, PT. Extension, it is the extension of the pharmacological action. So when you use these drugs for the long term or the overdose, then there is a bleeding in such individuals, which is characterized by the chymosis epistaxis, hematuria, bleeding in the GI to intracranial hemorrhage or internal hemorrhage. Sometimes it may be very dangerous, may lead to fatal condition. So you have to treat the patient as soon as possible by giving its antagonist. Okay. What is the antagonist of warfarin?
Vitamin K.
Yeah, vitamin K. So if you see the bleeding in patient who are taking warfarin, immediately you have to inject vitamin K, okay, to that patient. That is the antidote of warfarin overdose. It is more likely if the therapy is not properly monitored or interacting drug or contraindication are present. Okay, so in certain, that I have already discussed, no, drug interaction. If you don't ask the history, if you didn't ask the history of the patient who are taking any drugs interacting with the warfarin, okay, and if the monitoring is not done properly, like if the PT is not done in on the regular basis, in that condition there is excessive chance of bleeding. So this is a very common complication of warfarin. For this reason, you have to do PT monitoring, as well as you have to ask the history of the patient about the other concomitant drugs. Okay. Teratogenic effect, because it can easily cross the placental barrier. It has a teratogenic effect to the fetus. So it should not be given. It is contraindicated in pregnancy. Skin necrosis is also a common complication of this warfarin. Other like anorexia, diarrhea, alopecia, urticaria, dermatitis, and abdominal cramps. So these are the minor complication or the minor adverse drug reaction of warfarin. So how will you treat a patient which have bleeding due to warfarin? You have to stop the drug immediately. Okay, this warfarin, or withhold the anticoagulant immediately, give fresh blood transfusion. Okay, if there is a heavy bleeding, the patient may have the deficiency of the blood, so you have to give fresh blood transfusion, whole blood transfusion, or either you can give frozen plasma transfusion. Okay, and you have to give vitamin K specific antidote. So this antidote is the vitamin K, which takes about 6 to 24 hours for the clotting factor to be resynthesized and released in blood after vitamin K administration. So you have to immediately give vitamin K for the treatment of bleeding due to the warfarin overdose. So dose regulation is very, very essential while you are giving warfarin. Why? The things I have already discussed. Okay, because if you are not regularly monitoring the regularly monitoring the PT level, then there may be chance of bleeding in such individuals. Okay, the patient who are taking warfarin. So dose regulation is very must. Okay, must be individualized by repeated measurement of prothrombin time. What is the aim of dose regulation? Is to achieve the therapeutic effect without unduly increasing the chance of bleeding. Okay, so if you do this prothrombin time monitoring, then you will have the idea of what is the therapeutic level of warfarin. And if you increase the dose beyond the therapeutic level, obviously there is a bleeding. So to minimize the patient okay, to make the patient in the therapeutic level as well as to prevent from the bleeding. Okay, for that reason, always you have to monitor the prothrombin time. It is regulated based on the INR. Okay, it is another term for the prothrombin time. Okay, it is the international normalized ratio. So it is the ratio of the that clotting time of the patient divided by the standard or the reference range. Okay, that is given by the WHO. The optimum ratio of the prothrombin time during the treatment to the normal value. Okay, this normal value is the standard range that is given by the WHO. So in different conditions, different INR ratios should be maintained. Okay, and it should be individualized. If the patient is healthy, if the patient having any associated disease, okay, in that condition, you have to monitor the INR level accordingly. Okay, so because of this reason, this INR level is different for the different individuals. That should be individualized. Like for the prophylaxis of deep vein thrombosis and similar indication, this INR ratio should be between 2 and 2.5. Okay, whereas for the treatment of deep vein thrombosis, pulmonary embolism, okay, and if surgery, the range should be 2 to 3. Whereas for the recurrent thromboembolism, arterial disease, MI, prosthetic heart valves, it should be 3 to 3.5. Okay, for the different clinical condition, there is a different range of INR. It should be maintained in this range depending on the clinical condition of the patient. So this warfarin is totally contraindicated in pregnancy. So this is the additive contraindication of warfarin. Then other than heparin. Okay, all other contraindications are almost similar to that of heparin. So what are the contraindication of heparin? Have you remember? In which condition we cannot give heparin? So that contraindication is applied to warfarin also. What are the contraindication of heparin?
If there is bleeding disorders,
Okay, bleeding disorder, hemophilias,
Peptic
and
ulcer
okay,
patients.
okay, peptic ulcer patient and hypertensive patient also, any cardiovascular other problems, and the patients having. So these are all the contraindication of the heparin. Okay, so these contraindication are also applied to the warfarin also, and this other than this cannot be given in case of pregnancy. Okay, because it can easily cross the blood-brain barrier, whereas heparin can be given in pregnant lady as well. If you give in the early pregnancy, it increases the birth defect, especially the skeletal abnormalities. Okay, so in the early pregnancy, if you give these drugs, there is a hypoplasia of the nose, eye socket, hand bones, and a growth retardation. So birth defect is seen in early pregnancy. While when you give in the late pregnancy, cause CNS defect, fetal hemorrhage, fetal death, and the associated neonatal hypoprothrombinemia. So you should not give these drugs either in early pregnancy or in the late pregnancy. Okay, you should not give in any stage of pregnancy. So it is totally contraindicated. Indication is also similar to that of the heparin. So it can be used in deep vein thrombosis, pulmonary embolism, myocardial infarction, unstable angina, atrial fibrillation, and disseminated intravascular coagulation or DIC. Okay, but this drugs is always continued after giving heparin. Okay, in the initial you have to always give heparin because warfarin will take some times to show its action. Okay, it has a delayed onset of action. Due to this reason, always treatment is started with the heparin for around 5 to 7 days, and after 5 to 7 days, you can start with the you can give warfarin. Okay. and as well as you can give for the prophylaxis, because it can be given by the oral route. Okay. So there are other oral anticoagulant. So I have tabulated here so that it is easy for you. It is this other oral anticoagulant. They are differ only in their pharmacokinetic properties only. Okay, because they have similar indication. Adverse drug reaction are also similar. Mechanism of action also similar. So they have some differences in the pharmacokinetic properties only. That is in the T-half, duration of action, and dosing schedule. Okay. And adverse drug reaction is also almost similar. This hydroquinone T-half is 25 to 100 hours. It has a long half-life. Okay. So frequent GI disturbances. It has a common complication, that is GI disturbances. Warfarin sodium, besides bleeding, it has alopecia, dermatitis, diarrhea. Okay. In other drugs like the acinocumaril, it has oral ulceration, GIT disturbances, dermatitis, urticaria, alopecia, and other drugs. It is just you see the difference in pharmacokinetic properties. Okay, these are not very commonly used drugs. So you just go through only the difference with warfarin. What are the points that is different from warfarin? Just in the T-half and duration of the action, and some adverse drug reaction are different. Otherwise, other things are almost similar. So the differences between heparin and warfarin. Till now, I think all of you know what are the difference between heparin and warfarin. So the chemistry is different. It is a mucopolysaccharide heparin, whereas the warfarin is the coumarin derivatives. Source is hog's lungs, pig intestine, but it is a synthetic. Okay, warfarin is a synthetic compound or synthetic drug. Heparin should be given by the parenteral route, either intravenous, subcutaneous. Warfarin is given by the oral, because there is a 100% bioavailability of warfarin. Onset of action is immediate with heparin, whereas delayed in case of warfarin. Why? The reason also you should know. Duration of action 4 to 6 hours, 3 to 6 days. Okay, activity. Heparin can be used in vitro as well as in vivo. Whereas this warfarin can be used only in vivo. Mechanism of action is different. This heparin, they block the action of the factor 10 thrombin indirectly, okay, by enhancing the action of the antithrombin 3. Whereas this warfarin inhibits the synthesis of vitamin K dependent clotting factor, okay, 2, 7, 9, and 10. Antagonist also different. For heparin, antagonist is protamine sulfate, whereas vitamin K is the antidote for warfarin overdose. Okay, these are the differences between warfarin and heparin. And APTT monitoring should be done in case of heparin, whereas prothrombin time, PT or INR, is essential in warfarin therapy. Use is to initiate therapy. Okay, heparin is always used for the starting of the treatment, whereas warfarin for the maintenance. Okay, after giving heparin, you can you maintain with the warfarin. Okay, maintenance dose. After 5 to 7 days of giving heparin, then you can give warfarin as a maintenance therapy. So these are the important differences between heparin and warfarin. Next, we have direct factor 10A inhibitors. Okay, this directly go and bind to the factor 10 and inhibit its action. Okay, that's why name is given direct factor 10 inhibitor. In this, we have the rivaroxaban. Okay, this is the one drug that comes under direct factor 10A inhibitor. It is orally active, which causes direct inhibition of the activated factor 10, thereby inhibiting the cascade of coagulation. It is used for the prophylaxis and treatment of deep vein thrombosis. Because it has a rapid onset of action, you can use as a treatment also. Okay, this drug. By giving oral route also, you can give as a treatment and last for 24 hours. So it can show its effect within 3 to 4 hours and last for 24 hours. It doesn't require any lab monitoring like PT and APTT. Okay, no need of lab monitoring. So this is another advantage of this direct factor 10A inhibitors. Dose 10 milligram once daily starting 6 to 10 hours after surgery for prophylaxis of venous thromboembolism. So for the prophylaxis of venous thromboembolism, you can give 10 milligram once daily after total hip or knee replacement. Side effect: bleeding, nausea, hypotension, tachycardia, and edema. So in almost all the anticoagulant drugs, the common side effect is bleeding. Okay. Next is the oral direct thrombin inhibitor. So what are the parental direct thrombin inhibitor? Do you remember? We have the parental direct thrombin inhibitor and oral direct thrombin inhibitor. What are the parental direct thrombin inhibitor? Do you remember? In today's class only I have discussed just now.
Yes, ma'am. Lepidolin.
Yeah, lepidolin, vivaluridine, and these are the parental direct thrombin inhibitor. But we have oral direct thrombin inhibitor as well. Under this, we have the dabigatran etelaxate. Okay, this is a prodrug. Prodrug means after entering into the body, it will convert it into the other form. It has initially it is a dabigatran etelaxate. So after absorption and after metabolism, it is converted into the dabigatran. That is the active form. Okay. Directly inhibit the thrombin by reversibly blocking the catalytic site of the thrombin. Okay, it will directly go and bind to the catalytic site of the thrombin. Okay, thereby it inactivate this thrombin clotting factor. Okay, factor 2, and inhibiting the cascade, coagulation cascade. Produce a rapid anticoagulant action within 2 hours. Effect is persistent, no lab monitoring is required. So these are also advantage of oral direct thrombin inhibitor over warfarin. Okay, these drugs you can give for the treatment also because it has a rapid action. Plasma half-life is 12 to 14 hours. Duration of action is 24 hours. So you can use once or twice a day for the prophylaxis as well as treatment you can give. Okay, for prevention of venous thromboembolism following hip, knee, or joint replacement surgery. So you can use as a prophylactic drugs. The dose of 110 milligram once daily because it has a half-life of 24 hours. So you can give once daily for the prophylaxis for venous thromboembolic condition after the surgery. So this is the last drug we discussed in anticoagulants. Okay, I think this is the last PPT. Now we finished coagulants and anticoagulants. Today I could not give you this MCQs. Okay, and the next day I will prepare some MCQs and I will post in your that teaching learning team. Okay, I will give as an assignment. So thank you all of you for your attendance.
Ma'am, please upload the PPT.
Okay, I will upload it. So any doubt you have? So MCQs I will give you as an assignment. Okay, in another day.